If you or your child have a penicillin allergy stamped in, bold red letters on your medical record, there is a staggering 92% chance that label is just a complete lie.
Yeah, it really is. And we see the consequences of this every single day in hospitals and clinics.
Right.
When a patient comes in with an infection and they have that allergy label sitting there in their chart, doctors are basically forced to pivot away from first-line antibiotics, things like penicillin or amoxicillin.
Which is incredibly frustrating, I imagine. And that is exactly our mission for this deep dive today. We are investigating the massive overdiagnosis of drug allergies, specifically focusing on penicillin and other beta-lactam antibiotics.
Exact.
And we're going to explore how modern medicine is finally fighting back to delabel patients.
It's such an important shift in the field.
It really is. So to do this, we're pulling from a stack of 3 major foundational papers from the European Academy of Allergy and Clinical Immunology.
EAACI, yeah.
Right. So we have a 2014 pediatric study by Zambonino and colleagues looking at misdiagnosis rates. Then we have the incredibly comprehensive 2020 guidelines on beta-lactam hypersensitivity.
Which really rewrote the rule book.
Totally. And finally, a 2023 position paper on drug provocation testing, or DPT. And, to the listener, the stakes here are actually really high.
Oh, absolutely. Relying on second-line alternative antibiotics is not just some minor inconvenience.
No, not at all.
If you can't take penicillin, you are often prescribed a macrolide, which can cause, severe gastrointestinal issues.
Like really bad stomach problems.
Exactly. Or you might be given a fluoroquinolone, and that class of drugs carries a literal black box warning for risks like tendon ruptures.
Wait, tendon ruptures? Like your Achilles tendon could just snap?
Yes. Literally. Yeah. And all because of a medical label you might have been given when you were 2 years old.
That is wild. I mean, It's so similar to being banned for life from a restaurant just because you had a stomachache there once as a kid.
That's a great way to put it.
Right. Like you carry this lifetime ban, you miss out on the absolute best, most effective treatment options, even though the food, or in this case, the antibiotic, probably wasn't even the issue.
Yeah, and to really understand why this happens so frequently, we should look closely at the data from that 2014 pediatric study.
The Zambonino one.
Right. So researchers took 783 children who had been formally evaluated for a suspected beta-lactam allergy.
That's a pretty huge sample size.
It is. And remember, these were kids who had a clinical history that made their doctors confident enough to write allergic right there in their permanent files.
Okay, so they already had the official stamp.
Exactly. But then the researchers went in and ran exhaustive tests to actually verify those claims. And out of those 783 children, only 62 were confirmed to genuinely have an allergy.
Wow. Only 62?
Yes.
So that's what, just under 8%?
Yeah, under 8%, which means over 92% of those kids were completely tolerant to the drug.
That is just, that's a staggering failure rate. Which leaves us with this glaring question, right? If 92% of these kids aren't allergic, why on earth are they getting labeled as allergic in the first place?
That's a really fair question.
Are doctors just being overly cautious, or what's going on there?
Well, the failure really comes from the complex intersection of viral infections and pediatric medicine.
Okay, how so?
Children, as you know, frequently get viral infections, and when a child's immune system is actively fighting off a virus, it very often produces a widespread rash.
Oh, right.
We call it a viral exanthem. But frequently, when a kid spikes a high fever and just feels generally miserable, a pediatrician will prescribe an antibiotic like amoxicillin just to cover their bases for potential bacterial infection.
I see where this is going. So the child takes the amoxicillin, and then a couple of days later, the viral rash finally blooms all across their skin.
Exactly. And the parents, and honestly, very often the doctor too, they look at the timeline, they look at the antibiotic bottle sitting on the counter, and they just draw a straight line between the two.
So the drug basically takes the fall for the virus.
That is exactly what happens. The clinical history in these moments is incredibly deceptive. Pediatricians are looking at a distressed child and highly anxious parents.
Right, the parents are freaking out.
Exactly. So the safest immediate assumption is just to stop the drug and label it an allergy.
Better safe than sorry, in the moment.
Right. But the problem is that the label sticks forever. The 2020 EAACI guidelines emphasize that clinical history alone is just profoundly unreliable for diagnosing these things.
You can't just trust the story.
No, you really can't. You cannot just look at a child with a rash who happened to take a drug and definitively diagnose a hypersensitivity.
So to fix this massive overdiagnosis problem, allergists basically have to decode the reaction itself. And from reading the sources, it seems they've developed a highly specific framework for classifying reactions.
Yes, they have.
And the whole system revolves around a timeline, right? Like, how quickly did the reaction actually happen after the drug was taken?
Chronology is everything here, because the chronology dictates the biology of what is actually happening in the patient's immune system.
Okay, unpack that for us.
Sure. The framework divides reactions into two distinct categories: immediate and non-immediate. Immediate reactions occur very quickly, usually within 1 to 6 hours after taking the last dose.
Okay, 1 to 6 hours. Fast.
Very fast. And biologically, these are typically mediated by an antibody called IgE.
Right, immunoglobulin. These are basically the immune system's rapid response sentinels.
Exactly. When a patient is genuinely truly allergic, their body produces these IgE antibodies specifically attuned to recognize that exact drug.
Like a lock and a key.
Yes. So the moment the drug enters the bloodstream, it binds to these antibodies, which are sitting right on the surface of immune cells called mast cells.
Okay.
And this binding basically trips an alarm. It causes the mast cells to break open and dump massive amounts of histamine into the body.
And we all know histamine. That's what gives you the classic allergy symptoms.
Exactly. Histamine causes blood vessels to dilate and become leaky, which leads to those severe symptoms we associate with dangerous allergies. Things like hives, tissue swelling, or, in the worst cases, anaphylaxis.
Right, where your blood pressure just completely plummets and your airways constrict.
Yes, it's a medical emergency.
So immediate is fast, it's driven by histamine, and it is obviously very dangerous. To help visualize this, I like to think about household emergencies.
Okay, I like analogies.
An immediate IgE reaction is like a burglar alarm going off the second a window breaks. It is loud, it is instant, and the entire house is immediately on high alert.
That's spot on.
But the non-immediate reactions operate on a completely different timeline, right?
Yeah.
They use a totally different biological pathway.
They do. Non-immediate reactions don't show up for hours. In fact, very often they take days or even a full week to manifest.
Well, a whole week. Wow.
Yeah, and these are driven by T cells, not antibodies.
Okay, T cells.
Right, so instead of antibodies circulating rapidly in the blood, the drug interacts directly with T cells in the immune system. And then those T cells have to physically travel to the skin and initiate this much slower, highly targeted inflammatory cascade.
Got it.
The classic presentation of this is what we call a maculopapular exanthema.
Or MBE, for short.
Yes, MPE. And this just looks like flat red areas on the skin covered with small, slightly raised bumps.
So back to my analogy, a non-immediate T-cell reaction is more like a slow plumbing leak behind your drywall.
Oh, that's good.
Yeah, the water is dripping inside the wall, but you don't actually see the structural damage on the paint until days later.
That timeline perfectly explains why non-immediate reactions are the ones that get misdiagnosed so frequently.
Right, because so much time has passed.
Exactly. If a rash shows up 5 days into a 10-day course of antibiotics, the diagnostic waters are incredibly muddy. The doctor has to figure out if it's the slow plumbing leak of a T-cell reaction or just a concurrent virus finally showing its symptoms.
Which goes back to the kids with the viral rashes.
Precisely.
Now, while a mild delayed rash might sound, benign compared to sudden anaphylaxis, the guidelines make it very clear that non-immediate reactions carry their own severe risks.
I absolutely do.
Doctors are trained to look for very specific red flags.
Yes. While most non-immediate reactions are mild, allergists must be highly vigilant for what we call danger signs.
Danger signs.
Right. These signs point to severe cutaneous adverse reactions known as scars.
Scars.
Yes. And here we are talking about truly life-threatening conditions. Things like Stevens-Johnson syndrome, toxic epidermal necrolysis, or DRESS.
DRESS. Now, that is an acronym that pops up constantly in the 2020 guidelines.
It does.
It stands for drug reaction with eosinophilia and systemic symptoms.
Correct.
Now, the systemic symptoms part is pretty clear, but eosinophilia requires a little unpacking for us.
Sure. So eosinophils are a specific type of white blood cell. In a normal, healthy immune system, their primary job is to fight off parasitic infections.
Okay, so they're parasite hunters.
Basically, yeah. But in DRESS syndrome, the drug reaction basically tricks the bone marrow into massively overproducing these specific white blood cells.
Oh, wow.
Yeah, they flood the bloodstream. And crucially, they begin to infiltrate and attack healthy internal organs.
That sounds terrifying.
It is extremely dangerous. The danger signs that indicate this organ assault is happening include things like painful skin, blistering around the mouth or eyes, extreme fever, severely swollen lymph nodes, or signs of acute liver or kidney failure.
So if you have a delayed rash, but your lips are literally blistering or your skin physically hurts to the touch, that changes the diagnostic landscape entirely.
Absolutely.
It's not just a rash anymore. It's a potential internal organ assault.
In those specific cases, the drug is stopped immediately, and that patient is placed into a completely different risk category.
Which brings us to the major operational shift detailed in the recent guidelines. To combat this overdiagnosis without endangering people, the field has moved away from a one-size-fits-all approach.
Right. You can't treat every rash the same.
Allergists now use a system called risk stratification.
Risk stratification, yeah.
They categorize patients into high-risk and low-risk buckets. And they do this based entirely on the morphology, meaning what the reaction looked like and the chronology.
Yes, the timing and the look.
So the high-risk bucket seems pretty straightforward. Anyone who experienced anaphylaxis, severe breathing issues, or any of those severe skin reactions and organ involvement goes straight into the high-risk category.
Correct. No questions asked.
But the low-risk patients are the ones who experienced just mild, non-immediate rashes without any of those danger signs.
Exactly.
But wait, the guidelines also say the low-risk category includes patients who had isolated gastrointestinal symptoms.
Yes, that's right.
So if I take an antibiotic and spend the entire night hugging the toilet with severe nausea and vomiting, I shouldn't be on the never take penicillin list. That feels so counterintuitive.
I know it sounds counterintuitive, but nausea, vomiting, and diarrhea are incredibly common. But they are just predictable side effects of the chemical compound irritating your stomach lining or disrupting the natural flora in your gut.
So it's just your stomach being upset by the pill itself.
Right. A true drug hypersensitivity requires the immune system to misidentify the drug as a threat and actively attack it. Gastrointestinal irritation is a mechanical or chemical side effect, not an immune-mediated hypersensitivity.
Ah, that makes perfect sense.
So patients with isolated GI symptoms fall firmly into the low-risk or non-hypersensitivity categories.
Okay, so how a patient is stratified really dictates every medical decision that follows.
It's the roadmap.
For a high-risk patient, the standard protocol is strict, lifelong avoidance of that drug. Right. If they develop a life-threatening infection and penicillin is the only known cure, doctors might try some highly controlled skin tests, but generally the drug is off the table.
It's just too dangerous.
But for the low-risk patients, the diagnostic rules are basically being rewritten entirely.
Completely rewritten. Historically, even low-risk patients would be sent for extensive skin testing.
Right.
But skin tests are expensive, they are uncomfortable, and for non-immediate T-cell mediated reactions, they are notoriously inaccurate.
Really? Just not accurate?
No, because the immune mechanisms for those delayed reactions just don't always show up well on a quick skin prick test.
Which is where the 2023 position paper introduces the primary tool for modern allergists, the drug provocation test, or DPT.
Gold standard.
The concept is straightforward, but honestly, it sounds kind of radical on its face. The doctor deliberately administers the suspected allergy trigger directly to the patient.
Yep, you give them the drug.
Wait, feeding someone their supposed allergy trigger? Isn't deliberately giving someone a drug they're supposedly allergic to incredibly dangerous? How is this the gold standard and not, I don't know, a massive malpractice lawsuit waiting to happen?
It's a completely valid concern. But the safety protocols are rigorous. A provocation test is strictly contraindicated for any patient who had a severe reaction like anaphylaxis or de-dress.
Okay, so the high-risk bucket never gets this test.
Never. You never risk re-exposing those patients. But for the low-risk patients, the test is conducted under direct medical supervision in a clinical or hospital setting.
So you're not just doing this at home alone?
Exactly. The doctor has adrenaline and resuscitation equipment ready to go. The patient is given a highly diluted fraction of a normal dose.
Just a tiny bit to start.
Right. And if there is no reaction after a set observation period, the dose is incrementally increased until they reach a full therapeutic level.
And the major novelty in the recent data is that for low-risk, non-immediate reactions, particularly in children with those mild rashes we talked about, doctors are now increasingly skipping the skin tests entirely and going straight to the oral provocation test.
They are, and the pediatric study we discussed earlier really proved why this is so effective.
How so?
Well, out of the 62 children who were actually confirmed to be allergic in that study, 51 of them were diagnosed solely through the provocation test.
Wait, why?
Because their initial skin tests had actually come back negative.
Oh, wow. So the skin tests missed it.
Exactly. Putting a low-risk child through a painful panel of skin pricks often yields false negatives anyway. Bypassing that and doing a carefully controlled oral challenge provides definitive answers.
That makes total sense. Now, while the expert community agrees the provocation test works, reading through the guidelines reveals a really significant internal debate over how long the test should last.
Yes, this is a hot topic.
There is serious friction between advocates of a one-day test and those who argue for a prolonged test spanning several days.
It's a fascinating debate because it requires balancing global public health, individual biology, and complex human psychology.
Let's break that down.
Proponents of the one-day test argue for efficiency. The patient receives escalating doses over a few hours in the clinic, is observed, and then just goes home.
Nice and quick.
Right. And crucially, this minimizes the administration of antibiotics to healthy people.
Antibiotic stewardship.
Yes. Every time we give a patient a multi-day course of antibiotics when they don't actually have a bacterial infection, we contribute to the global crisis of antibiotic resistance and the creation of superbugs.
Which is a massive problem.
Yeah.
So a one-day test is clearly better for public health.
Absolutely.
But the advocates for the prolonged test, where you send the patient home to take the drug for 3 to 7 days, they argue that a single day might miss those slower biological reactions, right?
Yes.
Because if a T-cell reaction takes 5 days to develop during a real-world infection, just hanging out for a few hours in a clinic won't trigger the immune response.
That is the biological argument. But there is also a profound psychological hurdle that the one-day test struggles to clear.
Psychology, like the parents being anxious.
Exactly. When a parent has believed for years that amoxicillin will harm their child, watching their kids swallow just one pill in a clinic doesn't always erase that deep-seated fear.
I can imagine.
Studies actually show that even after a completely negative one-day provocation test, a significant percentage of parents will still refuse to give their child that antibiotic in the future out of lingering anxiety.
Oh, wow. So the medical label is technically removed from the chart, but it's not removed from the parent's mind.
You nailed it. But when a doctor prescribes a full 5-day provocation course to be completed at home, and the parent watches their child take the medication day after day with 0 adverse effects, it rebuilds that confidence.
It's like exposure therapy for the parents.
Essentially, yes. The successful completion of a real-world simulation provides the psychological reassurance necessary to truly break the cycle of avoidance.
So who wins the debate?
Well, because of these competing factors, the current guidelines don't dictate a rigid rule. They actually leave the duration of the test up to the specific clinical scenario and the physician's judgment.
Okay, that makes sense. So moving on a bit, the protocols we discussed for penicillin are now being applied to other medications too, right?
Yes, they are.
The 2023 paper expands the use of provocation testing to NSAIDs, which are painkillers like ibuprofen and aspirin, and also to iodinated contrast media used for CT scans.
And the landscape for NSAIDs is really defined by incredibly high rates of cross-reactivity.
Cross-reactivity meaning if you react to one, you react to others.
Exactly. The studies show that nearly 77% of patients who react to one NSAI will react to others, even if the drugs have completely different chemical structures.
77%, that's huge.
It is.
It's kind of like finding out you're allergic to one specific brand of cola, and then your body just decides to attack all dark sodas, completely regardless of the brand.
That is a fantastic analogy. And to understand why cross-reactivity is so high, we have to look at the mechanism.
Okay.
An NSAID reaction often isn't driven by specific IgE antibodies attacking the drug molecule itself.
So it's not like the lock and key we talked about earlier.
Right, it's not. It is driven by how these drugs interact with an enzyme in the body called KOX1.
KOX1, what does that do?
KOX1 enzymes help regulate baseline inflammation in the body. When a drug like ibuprofen naturally inhibits KOX1, the body's chemical pathways are altered. In hypersensitive individuals, blocking KOX1 causes the immune system to basically panic and shunt its resources down a completely different pathway. And this results in the massive overproduction of inflammatory chemicals called leukotrienes.
Leukotriene.
Yes, and these leukotrienes trigger severe asthma-like or allergic-like symptoms.
Wow. So it's like having an allergy to a specific factory process
Yeah.
rather than the factory itself.
Precisely.
If your body severely overreacts whenever a specific production line shuts down, it doesn't really matter if it's the ibuprofen factory or the aspirin factory flipping the kill switch. the mechanism shutting down is what triggers the alarm bells.
Exactly. And because of this specific mechanism, skin tests are poorly validated for NSAIDs. You cannot rely on a skin prick to tell you if an alternative painkiller is safe.
Because the skin prick doesn't trigger that whole factory process.
Right. So the provocation test is really the only reliable way to prove tolerance.
Got it. Now, what about contrast media? The dyes used in radiology.
That presents a slightly different challenge. Many people carry a contrast allergy label, which makes doctors really hesitant to order crucial diagnostic imaging, like a CT scan.
Which could be life-saving.
Exactly. Now, for contrast dyes, skin testing does offer some utility, though it is highly nuanced.
Nuanced how?
Well, a negative skin test to contrast media does not guarantee the patient won't have a reaction during the scan, but it generally indicates that if a reaction does occur, it will be less severe.
Okay.
Conversely, a positive skin test strongly correlates with dangerous high-grade reactions.
So a negative skin test is a reassuring piece of evidence, but it is not a 100% guarantee.
Exactly.
If a patient needs a vital CT scan and has a history of mild reactions to the dye, the doctor might perform a skin test first.
Right.
And if it's negative, they follow up with a provocation test with the contrast media to definitively prove the patient's immune system can handle it before sending them into the radiology suite.
Exactly. The provocation test is really the final arbiter across the board.
Which brings us to the most practical takeaway for anyone listening to this deep dive.
Yes, the action item.
If you were walking around with a drug allergy label from childhood, perhaps you developed a mild rash after taking amoxicillin when you were 5, it is absolutely worth initiating a conversation with your physician about delabeling.
The data overwhelmingly suggests that the label is likely inaccurate.
But there is one final, almost philosophical detail buried in the clinical data regarding the permanence of our immune system.
Oh, this is my favorite part of the Romano paper.
It's fascinating. So let's say you were part of that very small minority of children whose allergy was completely genuine.
Okay.
Let's say your childhood allergy was a 100% verified IgE-mediated hypersensitivity to penicillin, the real deal.
The long-term tracking data reveals that up to 30% of those patients actually lose that biological sensitivity within a single year.
30%.
In just 1 year.
Yes. Furthermore, over 60% lose it completely within 5 years. That is incredible.
The immune system is not static. The specific IgE antibodies that once triggered an immediate life-threatening reaction can naturally just wane and disappear over time.
So the body quietly moves on and basically forgets the threat, but the medical record does not update itself until it is actively challenged.
Right.
You could be carrying a lifelong medical restriction for a biological condition that your immune system quietly resolved a decade ago.
It really makes you wonder, are we carrying around lifelong medical labels for temporary conditions?
It's a huge question.
Even if your allergy was undeniably real at the time of diagnosis, your immune system may have already forgiven the drug, but it requires testing to actually find out.
So we invite you to look at your own medical history with newfound curiosity. Maybe it's finally time to find out if that childhood ban can be safely lifted. Thank you for joining our deep dive, and we'll see you next time.